How to insert an IV cannula. One of the most fundamental, yet life-saving procedures you will ever perform as a nurse, doctor, or healthcare professional is IV cannulation. This small blue cannula in your hand is more than just a plastic tube. It is a lifeline. It is the fastest route to relieve pain, to rehydrate, to deliver antibiotics, to transfuse blood, and to save a life in an emergency. When done well, it brings comfort. When done poorly, it brings pain, infection, and fear. Today, we will not just learn how to insert an IV cannula. We will learn how to do it safely, competently, confidently, and compassionately. Step by step, you will understand not just the how, but the why behind every action, from patient preparation and infection control, to vein selection, technique, and aftercare. This skill separates a nervous beginner from a trusted professional. Master it, and you will earn the trust of your patients and the respect of your team. Let's begin your journey to becoming safe, skilled, and confident in peripheral intravenous cannulation. Learning objectives. What you will be able to do. 1. Explain the indications, contraindications, and equipment for IV cannulation. This helps you understand when IV access is truly needed, when it should be avoided, and what tools to prepare for a safe procedure. 2. Select an appropriate vein and cannula gauge for the clinical situation. This ensures you choose the safest and most effective site and size to deliver treatment while minimizing discomfort and complications. 3. Perform the insertion procedure using correct aseptic technique. This is essential to prevent infection and protect both patient and provider during the procedure. 4. Recognize, prevent, and manage common complications. This prepares you to identify early signs of problems, take preventive steps, and respond quickly to keep the patient safe. Definition. What is an IV cannula? An intravenous IV cannula is a short, flexible plastic tube inserted into a peripheral vein through a hollow needle, which is then withdrawn, leaving the soft catheter in place. This design is important because only the soft plastic remains in the vein, which reduces injury to the vessel wall and allows the cannula to stay safely in place. It provides a reliable, semi-permanent route directly into the venous circulation for fluids, medications, blood products, and diagnostic sampling. This is essential because it gives rapid and direct access to the bloodstream for urgent treatment and routine care without repeated needle pricks. Also known as Peripheral IV, PIV, Venflon. IV catheter, angiocath. Indications. Why we cannulate a patient. 1. Fluid and electrolyte therapy, correcting dehydration or imbalance. This is necessary because IV fluids restore volume and electrolyte balance much faster than oral intake when the patient cannot drink adequately. 2. IV medication, rapid, titratable drug delivery. This is important because drugs given directly into the vein act quickly and doses can be adjusted accurately according to the patient's response. 3. Blood products, transfusion of blood or components. This provides a safe and rapid route to replace blood loss and improve oxygen carrying capacity in emergencies. 4. Blood sampling, repeated or difficult venous access. This helps reduce repeated painful needle pricks by preserving an already established access for sampling when needed. Safety first. Sites and situations to avoid. 1. Limb with an arteriovenous avenue, fistula or graft. This must be avoided because cannulation can damage the fistula, cause bleeding, infection, or clotting and compromise dialysis access. 2. Post-mastectomy side with lymph node clearance. This should be avoided because lymphatic drainage is impaired, which increases the risk of infection, lymphedema, and poor healing. 3. Area affected by cellulitis, phlebitis, or infection. This is avoided as inserting through infected tissue can spread infection into the bloodstream and worsen inflammation. 4. Limb with a fracture or planned IV site nearby. This is avoided to prevent further tissue injury, dislodgement, and interference with surgical or orthopedic management. 5. Sclerosed, thrombosed, or previously infiltrated veins. These veins should be avoided because they are damaged, more painful to cannulate, and more likely to fail or cause complications. 6. Paralyzed or edematous limb, where possible. This is avoided where possible because sensation is reduced, swelling obscures landmarks, and drug absorption and infection risk are increased. Preparation. Equipment you will need. 1. Non-sterile gloves and apron. This protects you and the patient from cross-infection and exposure to blood or body fluids. 2. Tourniquet. This helps to distend the veins by temporarily restricting venous return, making them easier to see and palpate. 3. Skin antiseptic, e.g. 2% chlorhexidine in 70% alcohol. This reduces skin bacteria at the insertion site and lowers the risk of bloodstream infection. 4. IV cannula, appropriate gauge. This ensures the size matches the clinical need and the patient's vein for safe and effective delivery. 5. Sterile gauze, cotton swab. This is used to apply pressure after insertion and manage any minor bleeding at the site. 6. Transparent semi-permeable dressing. This secures the cannula while allowing visual inspection of the site and keeping it clean and dry. 7. Extension set, needle-free connector. This provides a closed system that reduces movement at the site, allows easy administration, and lowers infection risk. 8. 10 ml syringe with 0.9% saline flush. This is used to confirm patency, flush the cannula, and check for infiltration or resistance. 9. Sharps bin and disposal tray. This ensures immediate safe disposal of needles and contaminated materials to prevent sharps injury and infection. Device selection. Cannula gauge and color codes. Gauge, color code, typical clinical use. 14G, orange, trauma, rapid transfusion of large volumes. 16G, gray, surgery, trauma, blood transfusion. 18G, green, blood products, rapid infusion. 20G, pink, general infusion, most adult patients. 22G, blue, children, older adults, fragile veins. 24G, yellow, neonates, very small or fragile veins. Assessment. Choosing the right vein. Straight, well-supported vein with good visible or palpable length. Soft, bouncy, and refilling on palpation, not hard or cord-like. Avoid areas of flexion, wrist, antecubital fossa, when possible. Start distally on the non-dominant limb, move proximally if needed. Consider the therapy planned. Irritant drugs need a larger vein. Anatomy. Common peripheral insertion sites. 1. Dorsal metacarpal veins. Location. Back of the hand, good first choice, easy to secure. Distal site that is often visible, easy to immobilize, and preserves proximal veins for future use. 2. Cephalic vein. Location. Radial thumb, side of forearm and wrist. Large and relatively straight vein that accommodates larger cannulas and is easily accessible. 3. Basilic vein. Location. Ulnar side of forearm, larger, but less accessible. Larger caliber allows good flow, but deeper position and proximity to nerves and artery require careful technique. 4. Median cubital vein. Location. Antecubital fossa, reserved for emergencies, blood draws. Large and easy to locate in emergencies, but flexion at the elbow increases risk of dislodgement and phlebitis, so it is not ideal for long-term infusion. Rule of thumb: start at the most distal suitable site and preserve proximal veins for future access. Before you begin. Pre-procedure preparation. 1. Confirm the order, check allergies, and explain the procedure to the patient. To ensure the procedure is clinically indicated, prevent allergic reactions, and gain patient cooperation. 2. Gain and document informed verbal consent. To respect patient autonomy and meet legal and professional requirements. 3. Perform hand hygiene and don PPE, gloves and apron. To reduce risk of infection transmission and protect both patient and staff. 4. Gather and check all equipment, check expiry dates and packaging integrity. To prevent delays and ensure all items are sterile, functional, and safe to use. Infection prevention. Hand hygiene and aseptic non-touch technique. ANT principles. Identify and protect key parts, needle tip, cannula hub. To prevent contamination of critical parts that will enter the vein or connect to the infusion system. Never let a key part touch a non-sterile surface. To maintain sterility and reduce risk of introducing infection. Use a new sterile pair of gloves per patient. To prevent cross-contamination between patients. Maintain a clean, organized working field. To reduce accidental contamination and improve procedural efficiency. Skin antisepsis. Clean site with 2% chlorhexidine in 70% alcohol. Chlorhexidine provides residual activity and alcohol gives rapid kill of skin flora. Use a horizontal then vertical friction scrub, till the operator 30 seconds. Friction ensures effective removal of microorganisms from the skin surface. Allow the antiseptic to air dry fully before puncture. To achieve full antimicrobial effect and avoid stinging or diluting antisepsis. Do not repalpate the site after cleaning. To avoid reintroducing microorganisms to the disinfected site. Setup. Positioning and tourniquet application. 1. Position the patient's arms supported, extended, and slightly dependent below heart level. To promote venous filling by gravity and improve vein visibility and palpability. 2. Apply the tourniquet 10 to 50 cm above the intended site. To occlude venous return and cause distension of the vein without being too close to the insertion site. 3. Check a distal pulse remains palpable. The tourniquet should occlude venous, not arterial, flow. To ensure arterial circulation is attained while achieving venous engorgement. 4. Ask the patient to open and close a fist to help veins distend. To increase muscle pump activity and promote venous dilation. Procedure, Part 1 Insertion, Steps 1 to 3. 1. Anchor the vein. Stabilize the vein by applying gentle traction on the skin 5 to 7 cm below the insertion point with your non-dominant hand. To prevent the vein from rolling and to keep the skin taut for smooth entry. 2. Insert the cannula. Enter the skin at a 15 to 30 degree angle, bevel up, in one smooth, deliberate motion, watching for flashback in the chamber. To allow controlled entry into the vein and to confirm venous puncture by visualizing blood return. 3. Lower and advance. On flashback, lower the angle further, advance a further 1 to 2 mm to ensure the tip is in the vein lumen, then advance the catheter off the needle. To ensure both needle and catheter tip are within the lumen before threading the catheter, reducing risk of through puncture. Procedure, Part 2 Insertion. Steps 4 to 6. 4. Release and remove. Release the tourniquet, apply digital pressure over the vein beyond the catheter tip, then fully withdraw the needle into its safety shield. To restore venous flow and prevent bleeding while safely remove the sharp to avoid needle stick injury. 5. Connect and confirm. Attach a needle-free connector or extension set and flush with 0.9% saline. Checking for free flow, no swelling, and no patient discomfort. To confirm correct placement in the vein and ensure incontinency without extravasation. 6. Secure and dispose. Secure the cannula with a sterile transparent dressing and dispose of the needle immediately into a sharp spin. To stabilize the cannula, allow visual inspection of the site, and ensure safe sharps disposal. Aftercare. Securing the cannula. 1. Use a sterile, transparent semi-permeable dressing so the site stays visible for inspection. To protect the insertion site from contamination while allowing continuous visual monitoring for signs of infection or infiltration. 2. Label the dressing with the date, time, gauge, and inserter's initials. To provide clear documentation for ongoing assessment and to track dwell time. 3. Avoid tension on the extension set, loop and secure it to prevent accidental traction. To reduce risk of lodgement and mechanical phlebitis from pulling. 4. Immobilize with a splint only if placed over a joint and clinically necessary. To preserve joint function and patient comfort, using immobilization only when needed to maintain patency. Confirming success. Flushing and checking patency. The SASH mnemonic for line care. Saline, administer drug. Saline, heparin, lock, per protocol. 1. Flush slowly with 5 to 10 ml 0.9% saline using a pulsatile push-pause technique. To maintain patency, clear any blood from the lumen, and create turbulence to clean the catheter interior. 2. Watch and palpate for swelling, resistance, pain, or leakage during the flush. To detect early signs of infiltration, extravasation, or blockage. 3. Confirm free-flowing infusion with no signs of infiltration or phlebitis. To verify the cannula is correctly positioned in the vein and safe for use. 4. Document a successful, patent line before leaving the bedside. To ensure accurate communication, continuity of care, and legal record of a functioning device. Records. Documentation essentials. 1. Date and time of insertion. To track dwell time and determine when review or replacement is due. 2. Cannula gauge and site used. To guide appropriate flow rate selection and future site rotation. 3. Number of attempts. To reflect difficulty of insertion and inform vein preservation planning. 4. Practitioner's name, ID. To ensure accountability and allow follow-up if complications arise. 5. Patient response and tolerance. To record adverse reaction, pain, or complications during the procedure. 6. VIP Visual Infusion Phlebitis Score. To provide a baseline for ongoing assessment and early detection of phlebitis. 7. Dressing type applied. To inform future dressing changes and maintain consistency of care. 8. Planned review, re-site date. To promote timely assessment and prevent prolonged cannulation beyond safe duration. Patient safety complications and prevention. 1. Complication. Phlebitis description. Inflammation of the vein wall. Prevention, action. Rotate sites every 72 to 96 H. Use smallest suitable gauge. Regular site rotation and smaller gauge reduces mechanical irritation and chemical irritation of the vein. 2. Complication. Infiltration description. Fluid leaking into surrounding tissue. Prevention, action. Stop infusion, remove cannula, elevate limb. To prevent further tissue swelling and promote reabsorption of fluid. 3. Complication. Extravasation description. Leakage of a vesicant, irritant drug. Prevention, action. Stop immediately, follow local extravasation protocol. Vesicant drugs can cause tissue necrosis, so immediate action its tissue damage. 4. Complication. Hematoma description. Bruising from vessel wall trauma. Prevention, action. Apply firm pressure after removal. Avoid repuncture nearby. Pressure achieves hemostasis and avoids worsening bleeding or vessel injury. 5. Complication. Infection description. Local or bloodstream infection. Prevention, action. Strict asepsis. Inspect site at every shift. To prevent introduction of pathogens and allow early detection of infection. Know your limits. When to stop and seek help. 1. After 2 unsuccessful attempts, ask a more experienced colleague to try. To prevent repeated vessel trauma, conserve veins, and reduce patient distress. 2. Signs of arterial puncture, red, pulsatile blood, stop and apply pressure. To achieve hemostasis quickly and prevent hematoma or arterial injury complications. 3. Patient reports severe pain, tingling, or numbness during insertion. To avoid nerve injury which may be indicated by sharp pain, abnormal sensation. 4. No visible or palpable veins after a full, systematic assessment. To avoid blind or unsafe punctures and to allow consideration of alternative access or escalation. Key takeaways. Summary. 1. Assess the patient and select the smallest gauge that meets the therapy's needs. To provide adequate flow for treatment while minimizing vessel trauma and risk of phlebitis. 2. Maintain strict aseptic non-touch technique throughout, to prevent introduction of microorganisms and reduce risk of catheter-related infection. 3. Confirm patency with a saline flush before use, and document fully. To verify the cannula is in the vein and patent before administering fluids or drugs, and to ensure clear communication. 4. Inspect the site regularly and re-site at the first sign of complication. To allow early detection of phlebitis, infiltration, or infection and prevent further harm. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.